I'm excited to have Bejal Kikani join me for Let's Take a Bite out of CRS and Neurotoxicity. And Bejal's top five from her bio. She went to ECU for her undergraduate studies and UNC for graduate school. She has worked at UNC for over 15 years and has been in our malignant inpatient hematology team for 4 years. She is active in helping to roll out inpatient clinical trials and enjoys being a resource for CRS and ICANS management tips. She is also involved in DEI projects and enjoys teaching. And to keep her busy outside of when she is at UNC, she has 3 feisty and rambunctious kids, a 6-year-old and 3-year-old twins. So thank you, Bejal, for joining us. So outside of your professional bio, anything you'd like to share with our audience that you do in your spare time?
Well, spare time right now is very minimal, but something that I've done in the past that was pretty neat was I went skydiving when I was in graduate school here, and I loved it, and I would love to do it again.
Frightening, yes. Yeah, that's pretty exciting. So our webinar this afternoon has poll everywhere questions. This is what it will look like on your screen, and you will have a chance to practice in a moment. pollev.com/UNCLCN. Here are our disclosures. So our first poll everywhere question, cytokine release syndrome does not involve the possibility of multiple organ dysfunction that is most often caused by immunotherapy. True or false? We will give you a couple of seconds to have others participate. Looks like there's a unanimous response.
Yes. So it is true that you can have multi-organ dysfunction as a result of CRS due to immunotherapy.
And now I will turn it over to Bejal to share more.
Great. Thank you, Tammy. I'm really excited to be here and share this information. Before I got started, I would like to take a brief moment of silence to memorialize the victims in both Gaza and Israel. Thank you for that. Let's take a bite out of CRS and neurotoxicity. Cancer immunotherapy, particularly T-cell engaging therapies like bispecific T-cell engaging agents or BiTE agents have made impressive progress in the recent years. And as with most medical interventions, of course, there's going to be side effects to be aware of. And so we'll talk about that. I am a co-investigator on trials, but I receive no direct compensation. So we'll start out with a comfort level question. What is your current level of comfort for managing CRS ICANS as potential toxicities to immunotherapy?
So it looks like some moderate comfort people are comfortable with. So hopefully you can improve that and help people to feel more comfortable.
Yes. So our learning objectives are to examine the pathophysiology of both cytokine release syndrome and neurotoxicity, discuss the signs of these toxicities, identify the grade, and discuss treatment recommendations for CRS and neurotoxicity based on the associated grading. So why is this relevant to practice? As I mentioned, immunotherapy, is on the forefront of making forward progress in cancer-directed therapy, and in particular, the field of T-cell engaging therapies. There have been really great response rates to this, but of course, there's going to be some toxicities. And so being mindful and, learning and about these toxicities is, very relevant, especially for the APP, who is often the first responder or the person who gets the page from the nurse about a patient not doing well, first on the scene for a rapid response. And so the APP is going to be the person that everyone's looking to for guidance in that moment. So these are a few drugs that we are working with on the inpatient side currently. Blinatumomab was one of the first T-cell engaging therapies that was FDA approved in 2014. And since then, of course, we've had multiple other T-cell engaging therapies come about. And in addition to these, our team, MedQ inpatient team, has helped to roll out a lung cancer trial looking at tarlatamab, which is for extensive small cell lung cancer as well. And that has been rewarding experience. So we'll jump into CRS and pathophysiology. So cytokine release syndrome, what is it? It is an acute systemic inflammatory syndrome characterized by fever and multiple organ dysfunction that is most often caused by immunotherapy. So CRS, of course, can be caused by many other situations, such as infection or immune reconstitution. But most often it's, in this situation, we're talking about immunotherapy. And depending on the agent that is being used, the rates of CRS are going to depend on, every drug is going to have its own incident rate. And as you can see here, it's a multi-organ potential for disruption. And in addition to these symptom-wise, patients can have headache, feeling malaise, body aches, back pain. We once had a patient who was started on blinatumomab for relapsed ALL, and his only real symptom was excruciating back pain with the initiation of the drug. And we basically, had to kind of just push along and get him through it with adequate pain control. So understanding to understand the pathophysiology of CRS, it is prudent to understand the mechanism of action of these agents. So we have this picture to help us. So you have a T cell engager, so that's the drug, that attaches to an antigen on the tumor cell. And this attracts a T cell to that cell. The T cell then is attached to the tumor cell by this T cell receptor complex, which then allows the host T cells to attack the tumor cell. So this is honestly a very genius and idea and way to treat cancer, but of course there's going to be some side effects as a result of stimulating our T cells to attack these tumor cells. So as our T cells attack their cell lysis, this is going to promote a cascade event of cytokine release. Early on, it's been shown to, there's interferon production, cytokines like tumor necrosis factor, and these allow for the stimulation of the macrophages and endothelial cells. And when these are activated in this type of setting, that is going to promote the production of interleukin-6, which is one of the major players when we're talking about CRS. And if you see my little red star there, we'll come back to IL-6 because it is a key player. So because of these reactions that occur, there's this, we do administer these medications in a stepwise fashion. There's something called the first dose effect, which essentially is the medication's effect when the first time the drug is administered, the patient's disease is going to respond to it pretty quickly. And the hope is that, but the next administration, it's a reduced reaction or toxicity concern. And so starting at a small dose and increasing incrementally is the idea for this step-up dosing plan to reduce the risk of CRS and ICANS. So these drugs come in different formulations. There's continuous IV infusion, which is unique to the blinatumomab for ALL patients. There's sub-Q injections and 2 to 4 hour IV infusions as well. And this is relevant because, if we have a patient on a continuous IV blinatumomab and they have a reaction, there's going to be a question or the possibility of stopping the infusion as a direct intervention to the CRS or ICANS, versus when you have already delivered the medication in a sub-Q manner, there's nothing that can be done. We can't stop it. It's already been given. And so that's going to dictate the treatment thereafter. So this is just an example of a step-up dosing plan with teclistamab, which is a agent used for relapse refractory multiple myeloma. So, we started a very small dose 1 at 0.06 milligrams per kilogram, and then we monitor the patient for 48 hours. If they do not have a fever, we can move on to the next dose. If they do end up having a fever, then we'll wait until or any type of reaction or toxicity demonstration. We will wait 24 hours until to ensure that has been resolved before moving to the next step-up dose. So these patients are in the hospital with us, and we, they can be admitted here as long as 7 days or longer if they have toxicities that require not advancing to the next dose level.
So our next poll everywhere question is, what vital sign abnormality must be present in order to meet the definition of CRS? We have a couple of different answers coming in. We'll give you a few more seconds. All right, we're 50-50. What do you think, Bejal?
Yeah, so in order to meet the definition of CRS, there has to be a fever that is present. And this was introduced in the most recent CTACE guidelines version 5, which made it a definition point to include fever as a sign that must be present to call it CRS. Great. So we'll jump into our grading and management section now. So grading guidelines, there's several different guidelines out there. The most prominent and well-known to us are the ASTCT, which is the American Society of Transplant and Cellular Therapy, NCCN, and the ASCO. Here, when we recently revamped our CRS and neurotoxicity guidelines, we chose to use we based most of our protocol off of the ASCO guidelines, mostly because it was more in line with what we were previously doing, and the wording was much more fluid, and so that's what we based our protocol on. So when we admit a patient that could potentially have CRS or CRS, we include this in their chart. That way, anyone that comes, if there's someone covering at night, a resident or someone, they have this management guideline in the patient's chart. And we'll go through the grades. So for grade 1, essentially the only sign is a fever. And for this situation, fever is defined as anything, so 38.0 or higher. And at this point, we are doing supportive care, and, giving Tylenol, watching vital signs to make sure that things are not progressing or getting worse, checking labs more frequently. And, we, cannot forget that fevers can be caused by other things than CRS, like infection, which is particularly important in our immunocompromised patients that we're giving these agents to. And so we do follow our fever SOP, and we do blood cultures. And if they are neutropenic, we will start antibiotics. But if they're not, we wouldn't start antibiotics unless they have some type of localizing or focal sign of infection. So the grade 2 is going to be where you have the fever. In addition to hypotension, at this point, we're not needing vasopressors and or hypoxia. So that is controlled or managed by low flow nasal cannula. And we decided to use kind of a blanket definition for hypotension, less than 90 systolics, or if they're symptomatic. And at this point, we are using a drug called tocilizumab, which is something that we'll hear about just soon. And this is a IL-6 receptor antagonist. And the idea is kind of stopping that interleukin from, eliciting the CRS cascade that it does and the side effects that come about with it. And then for the hypotension for this grade, it has to be resolved with respond to 2 liter, at least 2 liter. If it's not respond after 2 liters, then we move on to the next grade. So for grade 3, things are escalating, getting worse. We have the fever plus hypotension where we're requiring a vasopressor and or hypoxia. And now we're to the point where we're needing a high flow nasal cannula, face mask, or non-rebreather. And at this point, we are talking about possibly doing an echo to assess cardiac function. Do we need to call the ICU team to let them know that this is going on? We would have to call them because they're requiring a vasopressor. So of course they would go to the ICU, and we would give Toci at its max dose, and add a dexamethasone now. And you can see there where it says, if on monumental, contact the MD prior to dex. And that's because on that, there's a certain clinical trial that wants us to, avoid moving to the dexamethasone. And so, we have to be mindful of the protocols. For grade 4, this is life-threatening. So this is going to be when we have a fever, and in addition to hypotension that's needing multiple pressors, and hypoxia that's requiring positive pressure BiPAP, CPAP, and ventilation. At this point, the patient's certainly in the ICU. We have maxed out our tocilizumab, and now we're moving on to higher dose methylpred, very high doses, and then hoping things kind of calm down. I thought this was a pretty neat depiction showing what is thought to be what is happening within the pathophysiology in relation to the grade. Early on, you're going to have more of the interferon and tumor necrosis factor, which is going to give you that lower grade, those signs. And symptom-wise, you're going to feel, the patients are going to kind of feel fatigued, malaise, headache, flu-like symptoms. And then as we progress, there's going to be, this is where IL-6 comes into play, because it's one of the major players with CRS, major cytokines, and it creates a positive feedback loop where, there's production of IL-6 because of the activation of the macrophages, and that is going to affect surrounding cells, which is only going to increase the production of cytokines, in particular IL-6, and on goes the cycle. So tocilizumab, it was FDA approved in 2017 for use in CRS. It is an anti-IL-6 receptor antagonist. It blocks the receptor so that IL-6 cannot attach to it to cause the inflammatory storm. So it's going to be preventing that effect. And then one big point, which we'll come back to later, is that it does not cross the blood-brain barrier. There have been some studies that have been looking at CRP levels, which is something that's produced or promoted by IL-6 to measure the effectiveness of the toci. But in experience, anecdotally, toci is kind of a miracle drug. It works really well, and we're able to get patients through the side effects to continue on with their step-up dosing. So we'll move on to a case study involving CRS. So we have a 68-year-old male with IgG kappa multiple myeloma presented for teclistamab initiation. So he received the drug on day 1, and then he did well. And so he received the second step-up dosing, and right before receiving the second dose, he developed acute left-sided mid-sternal and back pain, which improved with Toradol and Protonics, but then a few hours later was found to be febrile. So objective data we have is that 48 hours after the first dose, he was afebrile, normotensive on room air, but then a few hours later he was febrile to 39.2, but remained normotensive and on room air. And the ICE score, which is something that we'll talk about in a bit, it was 10 out of 10, and exam was otherwise benign. So our differential, it could be a lot of different things. CRS is certainly on the differential, but you have to think about infectious. Was he having an MI, aortic dissection? Was it just simply GERD? And so when we are at the bedside, we're ordering these, blood cultures for the infectious concern, EKG, troponin, and then CBC, CRP, and CMP to assess organ function. So this is CRS grade 1 because the patient only had a fever, did not have any hypotension or hypoxia, and so essentially we treated with Tylenol. So now we'll jump into ICANS. ICANS is immune effector cell-associated neurotoxicity syndrome, also called cytokine release encephalopathy syndrome. And I like to think of this as CRS that we see in the periphery, but in the CNS. And so that's kind of how I make logic of it. And this chart here kind of shows, the idea of when the endothelial cells are activated by the interferon and tumor necrosis factor cytokines that are released early on, is going to create this hyperpermeability of the endothelial cells and create a blood-brain barrier dysfunction. And this is what is going to allow the cytokines, in particular IL-6, to get into the CNS and cause CNS inflammation and then neurotoxicity. So, as I mentioned, so there's going to be this peripheral immune overactivation with, production of activation of macrophages and endothelial cells. And this is going to create that blood-brain barrier dysfunction, which is going to lead to the CNS inflammation. So we'll jump into the grading and management section now. So just like with our CRS, there's different grading guidelines, and we ended up basing our protocol mostly off of the NCCN. And this was majorly because our wonderful colleagues in the BMT group, our bone marrow transplant team, their ICANS management for their CAR T therapy mirrored the NCCN guidelines. And so we wanted to, mirror that. So I'd like to stop, collaborate, and listen. And we're going to talk about the ICE score here. So the ICE score is a tool that can be used to assess and determine the level of neurotoxicity. This is only one domain that is looked at when we're looking for or grading neurotoxicity. So Tammy, I'm going to evaluate your ICE score. Can you tell me what year it is?
2023.
And the month?
October.
The city that we're in?
We are in Chapel Hill.
And the hospital?
University of North Carolina.
Great. Can you tell me what this is?
A ring.
Mm-hmm. And how about this?
A watch.
And this?
A microphone.
Great. Very good. Can you show me 2 fingers on your left hand? Perfect. And can you show me your thumb on your right hand? And, if you can, write a sentence here. Today is a sunny day.
Today is a sunny day.
Perfect. Very good. And then lastly, I'd like for you to count backwards from 100 by 10.
100. 10.
Okay. You. So Tammy's ICE score, she was fully oriented, so 4 points. She was able to identify 3 objects, so that's 3, followed commands, and had legible writing that was similar to her baseline writing, and then attention, unfortunately, was 0. And so we'll document this as her baseline, and we assess an ICE score on patients on admission and on a daily basis. And then, of course, if there's a concern for neurotoxicity, we would assess at that point. Good job. So that leads us to our ICANS grading. As I mentioned, the ICE score is only one domain of the grading system. The other categories are going to be their level of consciousness, whether there are seizures, motor findings, and then concerns with ICP. So the major point with this ICANS grading system is that the category that is the worst is going to dictate the grade. So for an instance, if you have an ICE score of 3, but you also, you have a seizure, then you're automatically deemed a grade 3 ICANS versus a grade 2, which is where the ICE score would of 3 would put you at grade 2, but the fact that you've had a seizure, you're at a grade 3.
So our next poll everywhere question, a 28-year-old female with ALL with severe acute onset headache within 10 minutes of initiation of blinatumomab infusion. Her vital signs showed her to be afebrile. What is an assessment tool you would use to evaluate her neurologic status? So let's see who's paying attention. We're 50-50 again.
Yeah. So it is the ICE score that we would use to, that would be the tool that we could use. So that leads us into the management. So the management for ICANS is a little bit more straightforward. We're going to be jumping right into dexamethasone at grade 2 level, and grade 3, we're moving to the ICU, starting methylpred and Keppra for seizure prophylaxis, and grade 4 is high dose methylpred and treating status and hoping things calm down. We've had a few grade 3s here that were pretty intense and severe. So why is tocilizumab not on this chart? So like I mentioned earlier, TOCI is what's the short name of tocilizumab, does not cross the blood-brain barrier. And it can have the opposite effect of ICANS. So if you remember, TOCI is going to be the receptor antagonist for IL-6. And in the periphery, IL-6 is not binding anywhere because of the TOCI that was given. And so you're going to have this excess IL-6 just floating around. And then because of that dysfunction of the blood-brain barrier, you're going to see, more, that IL-6 and cytokines move into the CNS. However, we would administer TOCI in the setting of CRS and concurrently with ICANS. So our case study here, we have a 76-year-old female with relapsed refractory kappa multiple myeloma, presented for teclistamab initiation. Step-up dose 1 went well. The day after step-up dose 2, there was a rapid call for confusion, was not able to track, walk or follow commands, and generalized weakness. She did have a temperature greater than 38.0, but the remaining, she was normotensive and not hypoxic. And so that would put her CRS at a grade 1 because she only has a fever at this point. So let's break down the neurotoxicity aspect. So there was a rapid for confusion. She couldn't track, follow commands, was generally weak. So her ICE score was 0 out of 10, which is, the worst it could be. And so that's going to put her grade at grade 3 because her ICE score falls into that category. And we treated with dexamethasone, and because there was also CRS, concurrently toci was administered. And if you recall, we typically don't do toci at a grade 1 CRS, but this is a prime example of using clinical judgment. And these are guidelines, and in this situation, things were escalating very quickly, and we weren't sure, providers weren't sure how, what was going to happen, and so toci was given. Our next case study, we have a 73-year-old female admitted for teclistamab initiation. The day after step-up dose, the APP was called to the bedside for mild rigors, chills, and she had a mild headache. At this point, her vitals are stable. She's not febrile. Her ICE score was 10 out of 10. So she got some Demerol for the rigors, and because she wasn't febrile, Tylenol was deferred to avoid fever masking. And then 1 hour later, the patient became febrile to 38.1 and hypotensive at 89/41. So this is going to put her CRS at a grade 2 because she has a fever and she's hypotensive. She responded really well to IV fluids. She got the Tylenol, Demerol, and toci for the grade 2 CRS, and blood cultures were collected. Then the patient received home regimen of methadone, trazodone, gabapentin, and lorazepam. And then a rapid was activated for altered mental status, and she was awakening to voice only. So for her ICE score, she was able to do a couple of things, but not much. And so her score was a 3. And so that put her ICANS at grade 2. So differential wise, CRS, ICANS with seizure, sepsis, she's hypotensive, newly, or oversedation. And so she was sent to the ICU, started on a Narcan drip, received Dex. And interestingly enough, her 1 of 2 peripheral blood cultures did return positive for strep mutans, which she was treated for. And so one would, argue, would it be, was it more of a sepsis picture, or was it ICANS, or was it, it could have been multiple etiology.
Our next poll everywhere question. You have a 64-year-old male with multiple myeloma. He receives his first dose of talquetamab. 28 hours after dose, patient develops altered mental status with grade 3 ICANS without CRS. Which intervention would not be warranted for this patient? Maybe
Yeah.
we have to think about it.
Yeah.
How'd they do?
That's great. That's perfect. Great job. So, you're at the bedside and you are evaluating a patient. There are apps, very convenient apps that can help you guide through grading. And there's even management recommendations. And I highly recommend the CAR-Tox app. This was created by the CAR-T team at MD Anderson. And then we have created some dot phrases that, if you ever were to have a patient with receiving immunotherapy, you could use these guidelines in this protocol by finding these dot phrases within my list. So future directions, there are studies looking into whether you can do prophylaxis, steroids or Tylenol for CRS ICANS, and whether this reduces efficacy of the treatment. Other cytokine antagonists are being looked at. And of course, improving the safety of overall T-cell engaging immunotherapy.
So before we wrap up with our last poll everywhere question, if you have questions for Bejal, please submit them through Poll Everywhere once we get through this question. She will have a few minutes after we finish up here to respond to your questions. So now that you've heard from Bejal, what is your current level of comfort for managing CRS ICANS as potential toxicities to immunotherapy?
This is pretty good. Oh, coming down. Well,
but we have some that are more comfortable.
Absolutely.
So
that's great.
Great.
References, and then thank you for having me. And this is my awesome MedQ team. And we're on 4Oncology on the A side workroom. So if you ever have a question or need us, we're there and we're always happy to help.
Thank you, Bejal. This was really informative. Thank you for sharing your expertise. As you know, this is completely out of my area of practice, so I know I learned a lot. So thank you for being here and spending your time with us.
Yes, thank you for having me.
So please, any questions for Bejal, share them through Poll Everywhere. They could go up on the screen and we'll have a few minutes to chat with Bejal. So while we wait for some questions coming in, you had mentioned in the beginning about clinical trials in lung cancer, specifically small cell. Do you see some of these treatments coming more in the solid tumor world in the future?
Yes, absolutely. Immunotherapy is, across the board being investigated for liquid tumor and solid tumors. There was one drug on the list, the tebentafusp, which is for advanced uveal melanoma. So it's certainly something that is, we're seeing, where we will be seeing more of.
And I have a question about grade 1, for some of those that are continuous IV infusion, when they have a fever, do you stop and you initiate your fever SOP? Are you stopping the drug as well?
That's a really good question. So at grade 1, we are not stopping blinatumomab, the continuous infusion. We're considering stopping it when they're grade 2 and they have not responded to fluid boluses.
So you'll keep the infusion going, but still do a sepsis workup.
Correct.
And all of that. Great. So we have a question coming through. Thank you. Does the fever have to recur after antipyretics are given in order to document a change to a higher grade?
That is a very good question. So, antipyretics, Tylenol in particular is what we most often use, definitely can mask a fever. And this is a situation where you're using clinical judgment. And so you could have a patient that had CRS grade 1 with a fever and received Tylenol, but then becomes hypotensive. And in practice, I would treat that as the, next level of CRS, and manage it that way, because we do have to consider the fact that they received an antipyretic.
Thank you. What is the incidence of these reactions happening? Do most people have them?
Yeah, great question. So, every agent is going to have their own incident rate, but one of the risk factors or predictive factors that has been kind of continuously seen is the higher burden of disease there is, the more likely, we could see more of a higher grade reaction. So, certainly it depends on your disease burden, and sometimes, honestly, we can't predict who's going to react and who's not going to react. And they've actually done studies to show that having a reaction during your treatment with immunotherapy does not signify whether you're going to have a good response or not. So,
yeah, interesting. So for the record, I can count backwards from 10 effectively.
That was staged.
So just wanted to clear the air on that.
Yes.
So I know CAR T in certain situations can move to outpatient management.
Yes.
Do you see some of this potentially? Is there talk about how to manage maybe certain drugs if there's less incidence in an outpatient setting?
Yes, absolutely. So one of the drugs, the mosunetuzumab for follicular lymphoma, our team calls that the dinosaur drug because it sounds like it could be a dinosaur. We are seeing solely an outpatient unless they have a really high degree of disease burden. Then they're treated inpatient. And then, that is the goal, and the intention is to try to move some of these therapies to the outpatient world. And, of course, there's the logistical, concerns or, avenues that we have to navigate. So
sure. Well, now we have your lecture to educate people in the outpatient setting. So I relate to what you're saying with that reaction to tumor lysis syndrome, an oncologic emergency that we see. Yeah. I mean, lymphoma sees it, but we could see it in solid tumor also.
Yeah, exactly.
Great. Any other questions before we wrap up? How is CRS managed in the outpatient setting? So to add on, that's a great question.
That is a really good question. If they have a fever and they're on immunotherapy, at that point, they're already talking about admitting the patient for monitoring to ensure that they're not advancing to the next grade level. We've had a couple of patients that were, persistently febrile, but never had any hypotension or hypoxia. And the outpatient team felt comfortable having that patient manage at home and taking her blood pressures and O2 sats and coming into the ER. And so it's going to be patient dependent. It's going to be infusion center dependent. But, typically there's a low threshold to admit these folks.
Great. Thank you. Thank you all for being here. Thank you for your attention this afternoon. Also, thank you to the University Cancer Research Fund, to UNC Lineberger Comprehensive Cancer Center and the Lineberger Cancer Network, to our amazing telehealth team that are in the background making all the magic happen. Thank you to Tim, Benny, John, Oliver, Andrew, Patrick, Lindsay, and Barbara.
Thank you.